and we're good.
Hi, my name is Sarah. I'm a hard of hearing MP here in Michigan. Welcome to the Deaf House Talk. This month we're going to talk about the emergency room, why you would go to the emergency room, why the emergency room is important, what you would see at the emergency room. So we have two fantastic doctors here tonight. We have Dr. Jason Rotoli and we have Dr. Ivy Mirus. They're both from the University of Rochester and they're both very awesome. So before we get started, I wanted to let you know that if you're on the Facebook Live page, you can post your comments and questions. We will have a Q&A at the end of this talk where you can ask questions and we can have our doctors answer your questions. If they're able to, they might be able to answer some of the questions during the presentation as well. We also will have comments and resources during the presentation that you can click on and you can go to more resources during the talk. I wanted to thank you all for coming tonight and thank our tech team, our captioners, and our interpreters. So right now I'm going to hand this over to Dr. Jason Rotoli.
Thank you for introducing me. Dr. Ivy Mirus is supposed to be here, but we've had some tech problems and haven't been able to connect with him for whatever reason. He is now blocked from getting in. So I apologize that he's not here to present with me. But anyway, I'm from Rochester, New York. I work at the University of Rochester Emergency Department, Emergency Room. Some health talks we've done before. We've talked about the emergency room before, but I wanted to make sure that we could do this again. I want to be able to explain what the word emergency actually means when we're talking about the emergency room. And the difference between the emergency room or the emergency department and urgent care. So we'll discuss those differences. And we'll go through a few examples and scenarios having to do with the emergency room and what it looks like, okay? First, let's talk about why people are showing up at the emergency room. They go there for whatever reasons. There are some common reasons. Throughout the country, most of the individuals who show up at the emergency room are there because of some sort of chest pain. Or actually as well, abdominal pain. The common reason that people show up is dizziness and have passed out. Another common reason is from at the time having a fever. And the last most common reason is having a headache or migraine or pain. But there are several reasons people show up in the emergency room. Maybe you've experienced the emergency room yourself, you've had those experiences, you've had back pain, or you've had a headache, or you've had some sort of pain that you needed to have addressed. So wherever your emergency room visit was, what it looked like, you can let me know within the chat if you want to discuss that and let us know. So go ahead and let us know if you have those experiences yourself. So what we want to talk about right now, though, is specifically the word emergency and what that really does mean. It means any situation, a health situation, that causes your health to decline, to be impaired, to cause death, or it can be a problem with, a serious problem with your physical body. It's anything that it's something that happens quickly and that you are not able to get treatment for, that you cannot wait for treatment, let's say for tomorrow or the next day or next week. That's an emergency, something that you cannot put off treating or having taken care of. And the problems is something that you should talk to your PCP about, and maybe your PCP will direct you to the emergency room, or the PCP will ask you to wait and come into the office. So, urgent care. Why do people go to urgent care? And really, that is the place that is for things that cannot or should not be treated at the emergency room. You can go to urgent care without an appointment. You can use your insurance to be able to pay. You can pay in cash while you're there. And it also saves time. So urgent care, that deals with all kinds of health problems. For example, a cold, or a mild flu, or maybe sinus infection. Anything that has put pressure or pain on your sinuses, or a drainage or a fever or something like that within your sinus. So that would be a sinus infection. Bronchitis or pneumonia. Both of those are infections within your lungs. A mild asthma, and understand, mild, not severe asthma. Gastroenteritis, which means a bug in your stomach, a virus that has made you have a stomach ache, you're throwing up, you're having diarrhea, you're having gastral issues. So it's either a virus or a bug that you've gotten in your stomach. The problem is, also, of course, they can do minor surgeries, minor broken bones, minor lacerations, sorry. Minor, if there's a broken bone, there's a minor setting that can be done taking care of the bones. Those are the types of things. So again, the laceration is something that can be taken care of unless it's on your face or within your eyes. With that, you need to go to the emergency room. But other minor lacerations or cuts, that can be handled at the urgent care. So understand the difference between the two of those and when you need to go to the emergency room for those specific lacerations or cuts. If you go to urgent care, people are always trying to think, okay, so what happens there? I know what happens in the emergency room. Who takes care of me at the urgent care center? Most of the time, the urgent care center has a PA, which is a physician's assistant, or an NP, which is a nurse practitioner. Sometimes they have a physician as well, but understand that the physician may not have finished their residency at that point, or maybe they haven't been certified at that point. So so they might not have had the experience with primary care issues. It could be a doctor who's retired and practiced a long time ago and decided that he wanted to go back to work, or she wanted to go back to work, and urgent care was where they ended up going back to. So if they have knowledge of primary care, is questionable. So you need to know that that is a possibility with the individuals who face at urgent care. In the emergency room, emergency department, those, louder, they have the attending. Most of the time they are board certified. They have a level of knowledge and standard practices that they are aware of, and they're able to do the job that they're trained for. They have the accreditation and certification they need. They may work with a hospital connected to a university, so they may have residents there. But again, the resident is also working with an attending, so there's always someone overwatching and someone who's taking care of the patient care and what they are being given. So you should know the difference between the two of them when you're talking about who works at urgent care and then who works in the emergency department. So now that we've clarified that, what I'd like to do now is compare primary care, urgent care, and the emergency department. Those 3 locations when we're talking about them. When you go to your primary care physician, of course, you need an appointment. With urgent care, you do not need an appointment. With the emergency department, you don't need an appointment, which is nice. With your primary care physician, they know you. They're aware of you. They have knowledge of your past medical history, of who you are. Urgent care probably doesn't know you. You don't have a relationship with them. And the emergency department, you don't know when you get there who will be your physician. If someone has gone to the emergency room often, they may know that person, but most of the time they're not known by the doctor themselves. In your primary care doctor's office, you may have a little bit of a wait when you go to an appointment. When you go to urgent care, you will have a little bit longer wait. In the emergency room, you will have possibility of a very long wait to receive care. So let's talk about what kind of tests each of those locations do. Your primary care doctor can ask for blood work, but there is a limitation to that, the same as urgent care. It's a set amount of blood work they can request. But remember that in the emergency room, they can have a full blood screen blood panel done that needs to be done. In your doctor's office, it's very limited, maybe, that you could have an IV for whatever you need. The urgent care, yes, you could get it there. In the emergency room, yes, IV care, fluids, anything else, definitely that's available in the emergency department. When you're talking about x-rays or CTs or MRIs, you know, where they do an x-ray and you go in the machine and back out, obviously your doctor's office does not have one right there. The urgent care probably does not have an x-ray machine or those mechanisms that they can use. But remember, at the emergency department, that's where they have all of the mechanics that they need. They have the MRI, which again is the big machine that your body goes into very slowly and you come out. They have x-ray machines, they have x-ray techs, and they have CAT scan availability. So it really depends on what type of care you need when you decide that you need to go to who you're going to. Again, your doctor's office is for your more of your health care and keeping in contact with them. And then the other 2 are more for those urgent or emergent care that needs to be done at that moment. Let's check and see if anyone has any questions right now. When he's done. So let's talk about some common examples of emergencies. Remember before, I gave a list of the most common reasons a person shows up is for chest pain. Okay, so let's explain that. What happens within your body? What does that mean? You have 2 lungs, obviously. And when you draw in air, the air comes in through your throat down to your lungs, and it goes through your trachea. That's what that tube is called. Or another word is your windpipe. Once it goes in, then that splits off to each lung. So as you breathe, your lung fills up and goes back down. Your heart is located kind of in the middle of your 2 lungs. You have 3 you have 3 ventricles that go in there. Your trachea goes in. You also have your aorta. You have the things that your body connects from your throat going down into your heart. And your esophagus also controls going down. So all of those are part of your chest. So when you're talking about the possibility of having chest pain, it's important to know how your body is structured, how your body functions, what's connected to what. So that, for example, if you have a heart attack, well, what does that mean? Well, that means that something within your heart, there's a problem within your heart itself. For example, your heart beats. And remember, I just explained about the 3 channels that are part of your heart, the vessels that are in there. Most of the time, normal blood flow goes through in and out, and it's very normal. But if you have a heart attack, it means that one of those vessels has flattened out, or it's not letting the blood flow go through anymore. And you're not able, your heart is not able to get the blood that it needs to be able to keep pumping. So a heart attack is, it feels like, or what it looks like is, well, it's the narrowing of the arteries in there. You feel a chest pain, you feel a tightness in your chest, you feel very heavy. And sometimes people say that they feel like an elephant set on my chest. That's what it feels like at this point. The person starts sweating, they can't breathe, they may not be able to walk very far. And it just maybe possibility of feeling nauseous as well. Some of the symptoms are with older people are a little bit different than someone with a younger person. Maybe they will feel dizzy or weak, or, you know, the pain's not in the middle of their chest. The pain is farther down in their stomach, or maybe they're confused, or they're having a hard time figuring out what's going on. So people are not having an easy time figuring out what has happened to them or what is causing these pains. But there are some common symptoms that we need to know about. And again, remember, a heart attack means that the vessels are not working. So when we talk about a heart attack, let's discuss who is at risk of that. Generally, people age 30 and above, individuals who smoke, individuals who have diabetes, if they have high cholesterol, if they're a drug user, cocaine is something that can cause a heart attack very easily. Those are the risks that are involved with the possibility of a heart attack. Yep.
When we're talking about a heart attack, the only symptom is not just chest pain. There are many different areas of pain that you may experience. This is the reason why you'll have pain in your chest, is because sometimes there are blood clots occurring, which means that the normal flow of your blood through the vessels or through your veins, there's something that is stuck. It makes it so the blood cannot flow normally through the veins. There could be the infection of pneumonia causing issues. That could cause pain in your chest, as well as blood clots. Reflux. Sometimes it feels like it's called heartburn at times. That feeling could also be a symptom. Issues with your gallbladder, which is a very small organ in your body, located right on the right top side, kind of right below your liver. I'm sorry, right below your liver. So if you do have issues with your gallbladder, there will be times that it feels like you're having chest pain, but it's actually caused by your gallbladder. Shingles is an infection that people have had that is just like chickenpox. If you've had that in the past, as an adult, it's called shingles, and it can be very painful and can come all the way across your chest, causing that type of chest pain. You just may also have a muscle cramp, and that would cause that chest pain, which could give you the alarm thinking that you may be having a heart attack. But again, those are just things that could cause the chest pain. Looks like my co-speaker has made it in. Hello, nice to see you, comrade. I'm so glad my friend has made it back.
I am so happy to finally get in here.
All right, so I just finished talking about chest pain. So if you'd like to take over from here and discuss strokes and symptoms of strokes, you can go ahead and do that.
Sure.
Yep, catch me up. Did you talk about the heart attack and chest pain, those types of things?
Yep, we did that already.
All right, so let's talk about stroke, and let's talk about how chest pain and stroke, if they are related, and how they are such important warnings, because these issues with heart attack and strokes are very time sensitive in order to receive treatment. Time is of the essence. It is critical that you get treatment immediately for either heart attacks or strokes so that you have less permanent effects from those. Strokes can be caused because there's not enough blood flow happening to the heart or into the brain. Also, Dr. Rotoli just spoke about signed about heart attacks. There are 3 main blood ventricles, brain arteries, and your brain, I'm sorry, there are many arteries. Your brain has many arteries. So I have a sample for you to kind of show. So here, this little simple toilet paper tube is the same concept as your blood vessel. So when you're young, your blood vessels are beautiful, open, the blood easily flows through, no problems. Now, as you get older, if a person has diabetes, high blood pressure, and some other health problems that could cause damage to your blood vessels, which means they begin to narrow and your blood flow is constricted. It could be from high cholesterol, high blood pressure, or anything else that can damage those blood vessels and make them become narrow, which then causes the blood to have problems flowing through freely. If you do not have enough blood flow to the heart, you can have pain. If you don't have enough blood flow into your brain, that can cause a stroke. And again, time is of the essence. We want to immediately get that blood flow back to normal so that your body can respond in a more appropriate and healthy way. If there is a stroke, we have 2 different types of strokes that could be occurring. One type is what we call kind of like a bleeding stroke, but that's a hemorrhagic stroke. Hemorrhagic stroke. For example, again, with the blood vessel, let's say that there's something that has caused a leak, and the blood, as it starts to flow through the vessel, is not actually getting all the way through to your brain because of that leak. When that leak is occurring, it is causing bleeding in the brain, which will then cause the hemorrhagic stroke. Another type of a stroke is caused by blood clots. And again, that doesn't mean that there's no leak now in your blood vessel. What happens is it's blocked. The blood cannot get through. For example, something like this, there may be a narrowing and the blood is just blocked from flowing through. And that causes what's called an ischemic stroke, which means there's not enough blood flow to your brain. Now, both of these types of strokes can look exactly the same. So when you see certain symptoms, you will know that it's a stroke. So there's a really cool acronym. It's called FAST, FAST. FAST. And F means look at someone's face. Is one side of their face drooping? That's a sign of a stroke. If you see that, ask the person to smile. If they are unable to smile with both sides, then that means they may be having a stroke. One side of their face could be paralyzed, unable to move. It could be the left or the right side of the face. Usually it only affects one side though. And so it's called facial droop, F. A is aphasia, meaning the person is unable to speak because what they've looked for actually is people who use American Sign Language. They do have some of the same symptoms. They have a hard time producing sign. They just can't find the right sign, the right concept that they're trying to come up with. It's the same thing that happens to people who use their voice to speak. It just seems that there's a confusion in the way that people are able to communicate once they've had a stroke. So that's the A part, aphasia. S, I'm sorry. Actually, I'm sorry. Let me back up. I gave you the wrong thing for the acronym. So S actually stands for the speech, whether it be speech or sign. So F again is for facial droop. A actually stands for arm, whether one of the arms is hanging down and unable to be utilized. So if somebody has a severe stroke, they're unable to move one side of their body. So there may be, like, for example, the right side has all range of motion, whereas the left side would be very weak. You would be unable to lift it all the way above your head, or maybe you wouldn't be able to sign with one of the hands as normal. And again, this usually affects one side of the body. If both sides are weak, that's a different concern that actually has to do with a spinal cord issue, not having to do with a brain, not having to do with a stroke. Now, that being said, if you have facial droop as well as weakness of one of your arms, that could be enough of the symptoms to show that you are having a stroke. If you have that as well as speech or sign change, that is cause for a severe stroke. So 2 of those 4 symptoms means it could be a mild stroke. 3 of the 4, oops, sorry, let the interpreter go back up. 2 of the 3, either your face, your arm, or your speech are affected. That means that you're having a serious stroke. If you are having all 4, the T standing for time, meaning that the time is so important to get you there. So the 3 symptoms are your face, your arm, speech or sign, and then the T stands for time. You may need to, at that point, if you get to the emergency room, they may need to have surgical intervention. There may be certain medical procedures that make it so your vessels, your blood vessels are widened so that the blood can flow through. If there's a bleed, a leak that's happening, then they may be able to remove whatever the issue is. So there are many approaches to how to solve the issues of a stroke in the treatment. But the point is if you notice 2 of the 3 symptoms of face, arm, speech, or sign, get yourself immediately to the emergency room. If you notice a change in somebody, if you, again, notice that drooping, ask them to smile. If you notice that they're not signing appropriately, get them to the emergency room. 2 of the 3, get them immediately to the emergency room. Not urgent care, not your primary care physician. This is a matter for the emergency room. Oh, and just a second, looks like Dr. Rotoli would like to add. Hi again, this is Dr. Rotoli. I would just like to add about heart attack or chest pain, or maybe other symptoms that you may notice related to a stroke. If you are having chest pains or symptoms of a stroke, it's imperative that you go to the emergency room. It's okay to call your primary care physician to let them know. They will most likely refer you to the emergency room immediately. Please do not go to urgent care for any symptoms of a heart attack or stroke. They are unable to help you. So again, emergency room and chest pain means go directly to the emergency room as opposed to urgent care or primary care physician.
Myra asked a very good question. She asked, how do I know if I'm having a stroke or a heart attack? You talked about the pain, but how do we know? So Jason, would you like to expand on that?
Oh, I'm sorry. I was reading the other questions and I missed what you had said, Dr. Ivy there. Sorry.
No, that's fine. One of the audience members asked, how do you know if you have enough blood going to your heart or going to your brain? How do you know if you're having a heart attack? Well, if your heart isn't getting enough blood flow, then that causes that chest pain. That's that ache that we talked about before, that Dr. Rotoli said before. Some of the symptoms are, again, as Jason explained before, pain in your chest, sweating, pain that's radiating down your arm or flowing down your arm. Maybe someone has passed out. Those are the kind of symptoms that you see in men. Now, understand, there's an important thing to understand, that women are very different. Women have different symptoms when they're having a heart attack. Sometimes a woman feels a little bit of pain and then it goes away in her chest area. She's feeling kind of lousy. The pain going down her arm sometimes, but not always. Those are the things to watch for. But if you are talking about a heart attack and you're not getting enough blood flow, it will hurt. It will definitely hurt. Your heart needs to have that flow at all times. because understand that your heart is a muscle, and that muscle needs to have oxygen all the time. You can't stop without oxygen in your heart. So you need to have it. So if you have enough oxygen in your heart, you're fine. But if you don't have enough, then that causes that pain. And that's when you need to talk to the doctor when you go there. And if you really are having a heart attack, or the possibility that it may not be so serious, talk with your physician. But you need to be checked out if you're having those symptoms. If your brain doesn't have enough blood flow, that doesn't have a pain associated with it normally. Remember the FAST, F-A-S-T, the facial droop, the arm weakness, and the speech interruption or the change in speech pattern. Those are the things that you know if someone's having a stroke. Those are the symptoms that you look for in the indications.
Another question that I've saw in the chat, somebody has asked if it's a good idea to call my physician. Is it a good idea to call the physician to ask to go to the urgent care or the emergency room? Most of the time when we call, the doctor is your primary care physician. The nurse may be able to interact with you and then go talk to your doctor about what may be the best option for you. So it's okay to speak to them because the nurse obviously has medical knowledge as well. That was a very good question. Thank you. I am seeing that there's some few other questions.
I think there's another good question here. What is the difference between a heart attack and heartburn? Okay, a heart attack is very serious. We understand that. That is considered a serious problem. Heartburn, that word, I mean, it's a misnomer. It's misnamed. It's your heart is not on fire. There's no burning in your heart. And it doesn't have anything to do with the pain. It doesn't have to do with your heart. It's from acid in your stomach that's working its way back up the tube that is going down your throat. So sometimes it feels, for example, if you eat something, too much coffee, or if you eat something citrus, or if you eat something that just has that acidic feel to it, your inside starts to feel warm, and it's like this burn going up that tube again. They call it heartburn, but it is not related to your heart at all. But surprisingly enough, many people go into the emergency room and they go into the emergency department and they're getting checked out and they say, you know, oh, I've just been having this strange pain, this burn up and down my chest, and I don't know why. We have to check to make sure that your heart is working appropriately and if that is what's being affected, because we don't want to assume that, no, that's heartburn. It's not something we need to worry about. Because remember, people with heart problems or problems that occur with your heart, you know, again, heartburn is acid, and we know that, but people have had it. They might have experienced it before and they know, but let's suppose you haven't experienced it and you are having other symptoms, you're sweating, you're having pain, you're having other things. So when you go to the emergency department, they will be the ones to help you determine that if you haven't experienced that before.
I would just like to add to that. I do remember, it must have been a few years ago now. One of my patients was about 60 years old, and this is just like the perfect story about reflux, is what it sounded like when we were talking. And then, of course, I kept in my mind that women have different symptoms of heart attacks. And sure enough, after this patient's test, she was having a heart attack. It was not acid reflux. The reflux was a sign and a symptom that she was having a heart attack. I mean, it almost fooled me, which is why it's very important for all of us to keep in mind that women present much differently when they are having heart attack symptoms.
Right. You don't want to play around with anything having to do with chest pain at any time, because we're there to help and we want to help fix it. So it's better to not take any chances.
Absolutely. There was another question in the chat box that was asking about how COVID-19 had been impacting either the emergency room or urgent care protocols. As far as urgent care, really, they have taken over so many of the tests for COVID-19. If you are in need of surgery, or if you are in need to go to the hospital for something, or if you need to go to the hospital or something minor, minor is for urgent care, testing is for urgent care. Something major would be more for the emergency room when you're having a major ailment. Now, both the emergency room and the urgent care do need to figure out how to keep people social distance 6 feet when we're in the waiting room. They have set up little special areas for people that have blocked areas off so that people can have social distancing. Everybody is following protocols with masks. So yes, there have been a lot of changes that have happened. But as far as changing protocol, I would say that a lot of the elective surgeries are something that have been canceled and postponed until we get to a different place. We are starting to reschedule some of those non-emergency procedures. Anything else you wanted to add to that?
Any huge concerns about COVID-19 when they started, when we knew about it? We expected a lot of people that would come in with COVID, but we still had to take care of the individuals who had chest pains, who came in with heart problems, who came in with stroke symptoms. We still needed to take care of them. We didn't stop because COVID-19 showed up. So that was one of the bigger obstacles that we had within the emergency departments. Sarah, I think you had some questions that you were going to ask us that the Facebook audience had posed.
Okay, Dr. Rotoli and Dr. Mirus, we have a couple questions from the audience. One question that we haven't answered, that they're asking about like skin color or like nail color or lip, like if it's a different color, does that mean that the blood flow is not normal?
That is an excellent question. And the answer is yes, a resounding yes. If you are noticing that the pinks of the eyelid are becoming white, or the skin is becoming white and clammy, it means that the blood levels are dropping, possibly. If you notice that fingernails are blue, lips are blue, or getting a little blue hue to them, it means that the oxygen level is beginning to plummet. It is it's abnormal for that to be happening. Please pay attention to the skin color. Absolutely. That was a great question.
And sometimes when it's cold outside, you know, you come in from the cold and you look down and you can see that your skin is a little bit blue. Of course, that's normal. That's your body reacting to the cold. Your blood vessels are shrinking or minimizing. But when we're talking about blue on your fingertips and on your lips, yes, that's very much a concern. That, you know, that means there's something not working right. And it's not just because of serious cold. There are other reasons that could cause that.
So the next question is more of a comment. They said that they thought they were having a heart attack because they were having a lot of chest pain. So they went to the emergency room. The doctor finally diagnosed it as the gallbladder. She said that she felt bad for going to the emergency room, but the doctor and the nurse told her that it was good to be safe and sorry. And she's also saying always to check it out because it could be a problem with your heart. You have any comment?
Yes, remember I had mentioned that at times the gallbladder can fool you and have that kind of chest pain. They fool us sometimes with that. It's on the right lower portion, just hiding underneath the liver, which is just underneath the chest. So when that pain happens, it radiates up through the chest area, which can mimic a heart attack symptom. So don't feel bad, because it's our job to actually find out whether it's a heart attack, gallbladder, pneumonia, or whatever else the ailment will be. What's most important is that you went right away to the emergency room. And I feel bad for you that you did have a gallbladder issue, but glad it wasn't a heart attack.
And that's something to add to that is kind of, you know, personally, one of the reasons I like being in emergency medical care is you never know what's going to happen. You don't know what's going to show up. You know, from the patient's perspective, you don't know what's going on. You need to have something checked out. And for us to be able to find that, you know, the people that come into the emergency room, the people that come in with no pain and they look like they're fine, we think, okay, why are you here? What's going on? And they say, oh, you know, I just have a little bit of chest pain. You know, it's no big deal. It's just a little, well, okay, so why did you come then? Well, it just feels different. You know, my chest feels a little bit different. So we send them to test, we do everything. And guess what? They're having a heart attack. And all they're saying is, oh, just a little bit of pain. So we see everybody from the continuum that shows up. And most of the time, yes, people who have serious heart attacks, we can tell that. We know that. You can immediately get them. But every now and then there are people that show up and they're having a heart attack that they're just uncomfortable. It's just a little bit of a hurt. But it needs medical attention and it needs to be addressed immediately, you know, because when somebody says, oh, I'm sorry, I went to the emergency room, don't be sorry. That's our job. We want to do that for you. We want to make sure you're being taken care of. So that's the reason we're doctors and why we're working in the emergency room.
I wholeheartedly agree.
So this is a follow-up to the last question. The woman or gentleman had a triple bypass several years ago, and from time to time they felt like an elephant was sitting on their chest. And they went to the ER, and it turned out to be a false alarm. So they're asking, like, if they have that feeling or any other feeling, how do you know when to go to the ER or not?
Wow, a triple bypass. Let's explain what that means first. You know, the human body has veins that they go from your legs up to your heart, from your extremities to your heart. And those are, again, more blood vessels in there. They go into, the arteries go into your heart. And if those shrink, then that means that you're not getting the blood flow. So when you have a triple bypass, it means that you have to have a surgical procedure for that. But it's really, that kind of heart pain is serious. Is it urgent? It is, but if you've had a bypass, you need to go and be checked. You can't take any risks with your heart. You can't just pass it off. If you've had that surgery, if you've had problems with your heart, if you have a history of heart ailments and you have a chest pain, go and get it checked out. Don't think, oh, last time they said this. What if it's serious this time? It could be. Or maybe it was something that was negligible before, but now it is serious. So yes, go and get those checked out.
Absolutely. Remember, we talked about those three main blood vessels on the heart. When you are having a bypass surgery, it means that another vessel is replacing one of those three that are attached to your heart. It has to be moved up into another area. And so you can go around life after that fairly normally, but please remember that new blood vessel can also constrict, can also cause the issues. So if any of those have small leaks, because remember, there's many vessels that branch off from the three main vessels of your heart, those can cause pain as well. And it is imperative that you get to the emergency room immediately to have your heart checked.
I wanted to change direction. If we've been talking a lot about the heart and heart attack. I have a good question here. Is what happens if I go to the emergency room and the doctor says that they want me to stay overnight or be admitted to the hospital or I have to have surgery? So what would the next step be?
So if you've gone into the emergency department, it is our job to try and figure out what is wrong. And the big part of our job is trying to decide, are you safe? Are you safe enough to be going home? Or maybe it's safer for you to stay with us and you have to stay as an inpatient. It may be something that you have to stay overnight. It may be something that requires a surgery. There are so many other conclusions that could come from showing up in the emergency room. But if something has occurred and it requires surgery, then yes, you would stay within the hospital. You know, it could be 1, 2, 3 days. It doesn't, we don't know for sure because it depends on the reason for the surgery, what you would need the surgery for. What you can expect is that when you're in the emergency room, they will put an IV in your arm. They will admit you into the hospital to stay for whatever reason it is, and they will give you medication and fluids through that IV. It's a very quick process that they do to try and make sure that everything's taken care of. If you do require surgery, what then happens is that you cannot eat past midnight the night before, because if you're going to have surgery the next day, you cannot eat, you cannot drink. Jason, Dr. Rotoli, are there other things that they should expect when they're coming in and asked to stay?
Yes. When folks are admitted into the hospital, the emergency team does an excellent transition of care and a warm handoff, which means that they then contact the team that will be working with you and taking over your care. So it won't be the folks from the emergency room, but the team will also transition you over to the hospital team, and you'll be in good hands from there. All of your care goes along with you and that care plan. It's up to the hospital then to also, of course, decide what medications you should be on, if there is a special bed that you may need, if your legs need to be elevated, whatever the doctor's orders are from the emergency room, those will be honored when you're moved into your next care team. So sometimes when it is a very serious emergency and you must be rushed into the emergency room, there's not a lot of time to do those plannings and those transitions. So if something like that were to happen, of course, there would be conversations with you afterwards to figure out those next steps after the emergent issue was taken care of. Right now, one of the biggest changes from pre-COVID is that the emergency room at this point does not allow any visitors. And that means that most of the time my patients are sitting alone, waiting and getting treatment. And it is sad. It's quite lonely. We realize this. Now, if the patient is confused, is emergently ill, or is in the process of dying, then of course we bring the family in, or whomever their support person would be, and who would be able to advocate for them. That's a little bit of a different story. And also with children, with minors, we let the parents come.
Okay, the next question from the audience is, do you want to address any inequality in medical care or attention when it comes to different races, such as African Americans and Hispanic? And do you also treat patients that do not have health insurance?
Wow, we do not even have enough time to talk about that topic because it is so important and so very complex. I will say that my department and my residents study hard to try to learn about the different cultures that are in our area, to try to understand the people that come into our emergency room, how we can best work together to figure out a treatment plan and what is best for the patient. We do acknowledge the health disparities for people of color. People of color have less access to health information. They have less access to physicians, to medical services, and the emergency department is quite aware of those disparities. So for me, it doesn't matter the person's religion, gender identity, race, whether they have insurance or they do not have insurance. For me, our immediate goal is to take care of you.
The emergency department only has one thing, and that's safety net. That's to make sure that you are safe and that you're taken care of. The people who fall through the cracks, sometimes they come into the emergency department just because that's the only medical care they have. They don't have a primary care physician. They don't have someone they see regularly. And we try our best to connect them up with a social worker, to connect them up with a healthcare worker. But sometimes it's very difficult for that person who is coming to the department. They may not have transportation. They may not have the funding. They may not have other things. They may have a drug abuse problem. Whatever it is, they're showing up to us. And our door is open to anyone. We cannot deny care to anyone, and that is the law. It doesn't matter insurance, it doesn't matter anything else. If a person comes into the emergency room, they have a right to be medically seen and to have medical care. And that's what we do for you.
Okay, I'm gonna add the two-part question. The first question is asking if you're both deaf or hard of hearing or hearing and how you communicate with your staff. And then the second question is asking more about like what do your deaf and hard of hearing patients do if they need an interpreter or accommodation to communicate in the emergency department.
Both of us are hearing physicians. And so we speak with our voice with all hearing staff. We do have deaf physicians, deaf nurses, deaf social workers, and psychiatrists, and I use American Sign Language with them. I have deaf patients, therefore I sign directly with them.
Yeah. And myself, I'm Coda. So as Jason said, I'm hearing. But it's really cool because in the emergency department, sometimes it's a really loud place. There are beeps and alarms and machines and everything else going on. And the noise level is so high, you can't pay attention to anything. But when Jason and I are working together on the unit, we can stand distance apart and we don't have to worry about trying to get close enough to communicate. We can just stand and sign to each other from feet away, and we can explain about this patient's in there and that patient's in that. And we understand totally what the other person's saying. So that's a very cool thing about us working together.
Yes, it sure is.
And the second question was asking like what do the patients that are deaf and hard of hearing do about accommodations? Like can they have interpreters or do they have captions or clear math? What kind of thing can they get in the emergency room?
Very good question. At the hospital that I work at, we of course want to meet the deaf patient wherever they are. So we have 24/7 access to interpreting services who are some of the best in the nation. They are always in the hospital. We have staff interpreters. They're not standing around waiting for the deaf to show up in the emergency room because they're usually very busy already. But if I am there or if Dr. Ivy is working, then they usually come, the deaf patients usually come onto our care because we don't need an interpreter, can have direct communication. So that's wonderful. Now, of course, the interpreter will come when they can, and they try to stay the entire appointment. At times, depending on how long the appointment is, if the patient is there all day, you will have interpreters that switch out to serve the patients as well as the doctors. Now, some patients we have may be oral and they want to write. Some people want to have interpreters, or some want to utilize all three, which they can. Now, I want to also, I always emphasize with my residents, my colleagues, and other med students to please, I implore them to please make sure they always make sure to have a qualified American Sign Language interpreter to provide full access to medical information.
Yes, exactly. The University of Rochester is unique in the way that the number of deaf patients that we work with. The university has made a commitment to accommodating them. Unfortunately, throughout the rest of the United States, they don't have the experience that University of Rochester does. So the best thing you can do is advocate for your need for an interpreter. When you go into the emergency department, you know, everything happens very quickly and very fast there. And they want to make sure that you're okay. Sometimes they will ask you to use VRI. And if you have to stay in the hospital, then they will bring in a live interpreter. But it really depends on the hospital and the region itself. But really, yes, you have the right to an interpreter. You should have one. There is no excuse or any reason at all why the hospital will not accommodate you by giving you an interpreter and make sure one's present.
Some hospitals and universities do also provide deaf interpreters and certified deaf interpreters, which means they will have a hearing interpreter and a deaf interpreter working together to make sure that their access and the communication is very clear, especially in a very emergent situation. At times also, when we put in a certified deaf interpreter, that it helps a lot to communicate during very severe illnesses or very severe emergent issues. So those are available as well.
Okay, I think this is gonna be our last question because we have to wrap up. They are asking, how do you know when to call 911 and wait for the EMT to come, and when you should just drive yourself to the ER?
Ah, that's a tough question.
I think it depends on who was calling, who is ill, who is driving. If the person is having chest pains and they're having a medical emergency, how are they going to drive themselves there? If they have a broken arm or they have something else and someone else drives them to the emergency room, of course. I mean, but it's always a matter of making sure you get there safely. But if you're not really sure, should I drive myself? Should I take an ambulance? What should you do? Call 911. The dispatcher will advise you what to do, what the next steps are if you're not sure. So if you're kind of vacillating and not figuring out, should I drive myself or should I call 911? Call 911. The person you speak with will advise you and help you with what to do with the next steps.
Dr. Rotoli, do you have anything to add to that?
Yes, I would like to add on that some people, when they call 911, if someone doesn't have access to a car or any sort of vehicle for transportation and you call 911 because you need to get to the emergency room, or if a person doesn't feel good enough to drive, please call 911. That is considered an emergency. If you, at times, if you decide to drive yourself, maybe if you're like, should I call myself? Should I drive myself or call 911? You can try to call your doctor and ask. But once again, please don't hesitate to call 911 if it's a medical emergency.
Okay, so this concludes our talk tonight. I want to thank Dr. Rotoli and Dr. Mirus from University of Rochester. I also want to thank our captioner and our 2 interpreters. I want to thank the audience for coming, and of course our tech team that set this up. We're going to have our next Step Health Talk April 27th at 8 p.m. We're going to talk about maternal and pediatric health. So mom, babies, and kids. So that would be really fun and interesting. You can always look at our Facebook event page for more information and resources. And we also have an email address that we will post on that page as well if we have more questions. Thank you all for coming. And I hope you have a great evening. Stay happy and well. Thank you.
Thank you for coming to the Deaf Health Talks.